Thank you, sir, for that kind introduction. Good morning, one and all. And at the outset, I must thank the organizing team of Diabetes India, especially Dr. Bansi Sabu, for giving this opportunity. So, I'll be speaking on a topic that is managing insulin resistance the smart way. So, what I'll be speaking is in this following agenda, like I'll define what is insulin resistance, types and mechanism, how do we assess in brief, and then the management proper and how lifestyle modification is the best smart way of preventing insulin resistance. And there are some therapeutics which are currently available, and there are some therapeutics in the pipeline, which I'll be discussing. So coming to definition, the simplistic definition is that insulin resistance is impaired biologic response to either exogenous or endogenous insulin. But sometimes we don't get biologic response in the endogenous insulin, but in clinical practice, subnormal glucose response to a given concentration of insulin can also be taken as insulin resistance. Resistance may be pathway selective or tissue specific. So I'll be discussing on that, how pathway and tissue specific insulin resistance are different. So types and mechanism. So insulin actually is the main insulin sensitive tissues are liver, skeletal muscle and the adipose tissue, and all these tissues insulin exerts its action by binding to the insulin receptor. So you can see the insulin receptor here. One is the alpha subunit, which is extracellular, and the transmembrane is the two beta subunits of the insulin receptor. And there is differential action or the pathway specific insulin action. For example, once insulin binds to the alpha subunit, which is extracellular, it actually activates the post receptor pathway through the beta subunit. And there are majorly two pathways. One is the PI3 kinase pathway, you can see on the left side, and the another is the MAP kinase pathway, which you can see on the right side. So in health or during health, once insulin binds to the insulin receptor, the PI3 kinase pathway is the most active one, and it activates the liver, skeletal muscle and adipose tissue insulin sensitivity, and that is responsible for all the metabolic effects of the insulin action. But the other part is the MAP kinase pathway, and once MAP kinase mediated pathway is activated, it will be mitogenic. So what happens is that in insulin resistance, the PI3 kinase is blunted, so less of metabolic effects, and it is mostly diverted towards the mitogenic effects. And these are the sites of insulin resistance, and you can see the insulin binds to the alpha subunits, then it activates the beta subunits, and there are receptor internalization and the post receptor signaling. So at each step there might be insulin resistance. For example, the insulin binding can be defective by the anti-insulin receptor antibodies, and one of the cause of insulin resistance. Then it can be at the alpha subunit or the beta subunit, and the third part is the receptor internalization or the post receptor signaling defect. So all this pathway can lead to insulin resistance. Now, what are the causes of insulin resistance? Sorry. So causes of insulin resistance, we have defects intrinsic to the target cells or the genetic defects. For example, then I'll give the example there. Secondary factors affecting the target cells, specific hormonal or metabolic disorders, and the fourth one is the normal physiologic states. So we must remember what are the causes so that we can address the causes and manage the insulin resistance in a smart way. So IR mutation or insulin resistance mutation, defects in gene important for insulin action. Then there are stress, fasting, starvation, uremia, cirrhosis, diabetes and obesity, which are the secondary factors of the target cells. The specific hormonal disorders like excessive counter-regulatory hormones, like maybe in Cushing's, acromegaly, drugs, antibodies to receptor, which I just described. Then there are some normal physiological states where insulin resistance is maximum. For example, during puberty, advanced age, or during pregnancy. So there are many factors that influence insulin sensitivity. Age is one of the important factor, mostly puberty and in the elderly. Weight is important. Ethnicity, the dark races have got more insulin resistance. Distribution of body fat, visceral fat is more insulin resistant. Dietary pattern, the physical activity, the drugs which are used, they can produce insulin resistance. Gut microbiota is the newer concept where it can actually induce insulin resistance. Then there are genetics. So all these factors influence insulin sensitivity. And there is a common soil hypothesis, like insulin sensitivity is dependent on many factors, and it is also associated with many other comorbidities, and we call it as a common soil hypothesis. For example, obesity, diabetes, hypertension, dyslipidemia, MSLD, PCO, atherosclerotic cardiovascular disease, even CKD, Alzheimer's are all spectrum, or they are very common comorbidities associated with insulin resistance. So major sites of insulin resistance are three. One is the liver, muscle, and the adipose tissue. In the liver, if there is insulin resistance, that can lead to accelerated gluconeogenesis, glycogenolysis, increase in the hepatic glucose output, and increased synthesis and secretion of triglyceride-rich VLDL. If skeletal muscle there is insulin resistance, then less amount of uptake of glucose into the skeletal muscle, reduced glycogen synthesis, and increased deposition of the triglyceride. Adipose tissue, it will lead to increased lipolysis and release of free fatty acids, abnormal balance of adipocytokines, reduced adiponectin, and increase in the leptin and the resistin level. Now coming to the assessment part, assessment, we have to see there are common clinical symptoms or signs associated with insulin resistance like obesity, PCO or NFLD, and there are some signs which are very typical of insulin resistance. Those are acanthosis nigricans and skin tags, which we all come across very frequently. But clinically, how do we define, or uh, objectively, how can we define insulin resistance? Now, objectively defining insulin resistance through the lab values is difficult, but the gold standard is hyperinsulinemic euglycemic clamp. This technique is difficult, not done in routine practice, mostly in the experimental setup. But simpler calculation like HOMA-IR and the quickie or the quantitative insulin sensitivity check index are some of the common things by which we can detect insulin resistance. So HOMA-IR, many times we discuss about HOMA-IR. How do we calculate HOMA-IR? It is basically fasting glucose in milligram per deciliter into fasting insulin microunits per ml divided by 405. So that's the simplest method by which we calculate the HOMA-IR. Quickie is actually the logarithmic ratio, like 1 by log of fasting insulin plus log of fasting glucose. But however, the normal ranges, we cannot tell that HOMA-IR this much is the normal or this much is the abnormal, but it is the widely used for population to population. So for example, in the cup study by Dr. Mohan et al, there was HOMA-IR more than 2.58, which have been considered suggestive of insulin resistance. These indices are therefore useful for comparing insulin resistance between individuals, but not for determining whether a particular person is insulin resistant or not. So HOMA-IR and quickie are not very commonly used in the clinical practice. So it's mostly the clinical symptoms and the signs which are important. Now coming to the management proper, lifestyle modification, some of the therapeutics are there in our hand and some are in the pipeline, so which I'll be discussing briefly. So in the smart way, lifestyle intervention is the best therapeutic option, that is the dietary modification and physical activity. Any weight loss is going to help, and that we can achieve with dietary modification and physical activity. So the dietary modification is mostly calorie restriction, sodium restriction, and avoidance of carbohydrates with high glycemic load is the cornerstone of treatment. There are many concepts like chronotherapy or feeding window in a day, eating during daylight or nighttime. So there are concepts which are evolving. Total carbohydrate, types of carbohydrate, the sequential use of the nutrients. So all these things are important as dietary modification. Then there are many dietary patterns which have also evolved. For example, the Mediterranean diet, the DASH diet, the veg diet, the low fat, very low fat diet, low carb, very low carb diet, and the keto diet. But these are all very fancy names, but they don't really do great jobs, because multiple trials and meta-analysis have been published addressing the comprehensive effects of the dietary pattern, and they found that no single eating pattern has emerged as clearly superior to all other to all others for insulin resistance. So the key factors which we can follow is probably calorie restriction, minimize added sugars and refined grains, choose the whole foods over highly processed foods, and emphasize non-starchy vegetables. There are, however, some good evidences which are emerging about reducing insulin resistance with time restricted eating, or what we commonly call as intermittent fasting. And they have personalized 8 to 10 hour time range in eating is effective in practical lifestyle, and that modestly improves the glycemic regulation and also insulin resistance, particularly in this particular study. So ADA has come out with a plate model, and this is the ADA 2025, where the plate method have been highlighted. That's a 9-inch dinner plate. Half should be filled with vegetables and fruits or leafy vegetables. Rest quarter to be filled with lean meat and lean proteins like chicken, eggs, or tofu. And the rest 1/4 is by starchy carbs. And we should use water more than the fizzy drinks. So physical activity, I think my previous speaker have told in detail about physical activity in the last 20 minutes, and prescribing a structured and sustainable exercise program provides a more benefit in reducing insulin resistance. It requires both aerobic and resistance training, what she has told just before me. And aerobic exercise can directly augment insulin sensitivity, and resistance training boosts the muscle mass that can positively affect the glucose uptake. So these are some of the recommendations which I have highlighted. One is aerobic, you can do 5 to 7 times in a week, moderate intensity, either according to targeted heart rate or rate preserved exertion, more than 30 minutes per day of continuous or accumulated exercise, and it should be prolonged rhythmic activities using large muscle groups. Now resistance training is moderate intensity, 2 to 4 sets, 8 to 12 repetitions, and you can use anything like weights, resistance bands and all. Flexibility 2 to 3 times a day, stretch to the point of feeling tightness or slight discomfort, each stretching to hold 10 to 30 seconds for 2 to 4 repetitions, and it improves the types like static, dynamic and proprioceptive neuromuscular facilitation. Any weight loss is going to help, as I have told. Bariatric surgery has also helped reducing adipose tissue volume by whatever means improves the insulin sensitivity. Some of the technology which we can use, and there are tools to use for weight loss like track calories, sleep hygiene, meal timing and personalized health data, may be more of smart way of reducing weight. But pharmacological interventions are also important for reducing insulin resistance. Now this box is very important because insulin resistance we have discussed at the liver, at the skeletal muscle and at the adipose tissue. Now we have two drugs which are directly reducing the insulin resistance and currently available. One is for the liver, that is preventing gluconeogenesis, which I'll be discussing with metformin, and at the adipose tissue, the fat storage, that is the PPR gamma agonistic activity for fat storage. But there are some other drugs which are in the pipeline, like improving the fat oxidation, like the acetyl CoA carboxylase inhibitors and the GPAT and the DGA2 inhibitors. In the skeletal muscle, no proper drug has evolved, but UCP3 activation or uncoupling protein 3 activator is a very important drug which is in the pipeline. MSTN inhibitors in the muscle mass also in the pipeline. So currently available options for iron reduction is metformin, mostly reducing the hepatic glucose output by MP kinase pathway. Thiazolidinediones, as has been discussed just before me, it reduces the it increases the insulin dependent glucose disposal in skeletal muscle and adipose tissue, and decreases the hepatic glucose output and promote fat redistribution mostly. GLP-1 and SGLT2 inhibitors, they reduce insulin resistance, but no direct reduction in the insulin resistance, maybe indirectly through loss of weight. Therapeutic strategy which are in the pipeline. Now there are drugs which are targeted at the liver and drugs that are targeted to the skeletal muscle. Some of the liver specific agents are therapies which reduce the hepatic diacyl glycerol and acetyl CoA contents by suppressing the hepatic de novo lipogenesis and reduces the fatty liver. It includes agents targeting the acetyl CoA carboxylase 1 and 2, and the DG82 are in the phase 2 clinical trials for treatment of not only MASH but also reducing the insulin resistance indirectly. Skeletal muscle specific agents increasing fat oxidation and or increasing the skeletal muscle mass is important because it reduces the intramyocellular lipid content, and that is mostly responsible for insulin resistance. There are some drugs like uncoupling protein 3 or an inner transporter that dissipates mitochondrial proton gradients may protect against the insulin resistance, and it will be helpful in the reducing the muscle insulin resistance. So coming to the conclusion, insulin resistance is impaired biological response to either exogenous or endogenous insulin. It is associated with various risk factors and comorbidities which I have discussed. Managing insulin resistance should be targeted to reducing the insulin resistance at 3 points. One is the liver, skeletal muscle and the adipose tissue. Currently we have metformin and thiazolidine only in our hands for both liver and also the adipose tissue insulin resistance, but many therapeutic agents which are targeted at the liver and the skeletal muscles are also in the pipeline, mostly in the phase 2 and 3 clinical trials. So with that I land. Thank you for the patient hearing.